So to my left, we have Dr. Joe Tector. Dr. Joe Tector is not only a great kidney transplant surgeon and a surgeon, but also been working on xenotransplantation, which is around the providing of pig kidneys on humans, and getting very, very close on our research of that. To his right, we have Dr. Giselle Guerra, Miami product. She is the director of Miami Transplant Institute and a great doctor in her own right. In the middle, we have Dr. Rodrigo Vianna, director of Miami Transplant Institute, a great liver surgeon. 80–90% of the multivisceral organ transplants, multi-organ transplants that happen in the United States get done through him. And to his right, we have Dr. Tiago Machuca, tremendous thoracic surgeon, not only for lung oncology, but also for lung transplant. So we have a great team here. Let me sit down and keep going. The Miami Transplant Institute, which I'm very proud to have as part of our team at UHealth Jackson, and being one of our true services at UHealth Jackson, is one of the largest transplant programs in the country. It brings together, like I said, the partnership between the University of Jackson in its utmost, and together we've been the state's only program in dealing with multi-organ transplants, and really in the southeastern United States. And we also do all solid organs in transplantation, which again is the only one in the state. So without any further conversations about what Miami Transplant does, we're here to talk a little bit more about what are the latest and greatest things in transplantation. So let me start off with Joe Tector. And Joe briefly talked about xenotransplantation. Tell us a little more about what you're doing and what that means once this has the breakthrough.
Sure, be happy to. So one of the things about transplantation is it's fantastic, and it transforms people's lives and it puts their families back together. But the challenge is not everybody can get one because there are not enough organs. And so we have spent longer than we care to talk about developing a way to make it so that you can use pig organs to transplant into people. And so we've been using genetic engineering and pig cloning in our lab at the University of Miami and Jackson Health to make these new pigs. And so we've got organs now that you and I have no antibodies against. And so now we're in the final stages of preparing to do a formal clinical trial here at Jackson Memorial Hospital so that we can start transplanting everybody that needs a kidney transplant, and we'll go to other organs. But it'll happen so that you can get transplanted when you need it without an incredible wait, and that everybody will have a chance.
Thank you, Joe. Artificial intelligence is obviously a conversation everyone talks about, but Giselle, talk to us a little more about how we use artificial intelligence in a way to really find matching for organs, and how we've developed artificial intelligence in that matter and any other matter.
So first of all, thank you for this opportunity to share this knowledge with everybody here. To piggyback on what Dr. Tector was talking about, we are in desperate need to help millions of people that are out there that need organs. And so it's not only about getting the right organs, but finding the right match. So I truly believe with technology and the use of AI, we're going to find the best organs for all these recipients that are in need in order for them to not only save their lives, but improve the quality of their lives. And we see it all the time. There's more and more different protocols, different programs that are being set up with AI to actually enhance and make those right matches that we're in so desperate need. Because at the end of the day, the list continues to grow. There's more individuals that are living longer because medicine has advanced so much, as well as the surgeries. But what's missing is, how are we going to make these organs last longer? And the only way to do that is to find the best matches. And AI is the key to make this happen. So transplant surgery over the last 40 years have gone through tremendous transformation. When I got to Jackson 13 years ago, a liver transplant would take between 10 and 11 hours for surgery. Today, that number, I don't want to insult them, it's under 2. What that means is not just quicker for the surgeon, but it's much better for the patient and the outcome, and how
much it takes. And by the way, the same can be said about lung transplantation. Maybe not the same hours, but the period of times, the reductions that it has. We're now at a point in which robotic surgery and soon in the future, remote surgery will be taking place in transplantation. I know that Rodrigo has done many robotic surgeries already in transplantation, and I know that Tiago has been talking about doing that in lungs as well. So, Rodrigo, why don't you start talking a little bit about robotic surgery and remote and what that means?
So thank you, Carlos. I'd like to thank the Emerge organization, Jackson, and University of Miami for the opportunity to be here. And actually, robotic surgery is changing not only surgery, but changing transplantation. Just for you to have an idea, at Jackson, we've been doing kidney transplant, living donation, not only the donor, but the recipient entirely robotic, with a very small incision that's called a funnest tube incision that actually hides under your pants. So you walk around, you had a kidney transplant, you donated a kidney, and nobody can see your incision. Actually, most of the donors go home the same day. If you can imagine and you can donate a kidney and go home the same day or the next day, that changes the field. Another example, we've done at Jackson the first fully robotic pancreas transplant in the world. Can you imagine how many diabetics can be helped by not only a kidney transplant, but at the same time receiving a pancreas transplant that really changes diabetes and really improves the quality of life? I think we're progressing to the time that augmented reality, the robots are going to be much smaller. People are working already on glasses where you're going to be inside the body wearing goggles, and you're going to have small controls in your hands, and that's going to fit in a suitcase. So the reality is that we're going to walk into any OR, and we're going to plug into the robot and perform surgery. Another revolution is training. Can you imagine with the 5G or with a wireless connection, I can plug in anywhere and help a colleague that could be in another continent or it could be in another hospital having trouble, or train millions of people that want to be surgeons or go really far. We're actually planning an intercontinental surgery that I don't know when it's going to happen, but we're planning on it. But of course, you have to be safe. Like, you have to make sure that wireless or the connection works. But I have no doubt that that's the future, and I think that's how healthcare is going to progress. Thank you.
If you think in the field of lung transplantation, for us to be able to do a double lung transplant, that is one of the most traumatic incisions that a patient can have. So just imagine, it's called a clamshell incision. So it's an incision that goes on both areas of your anterior chest, and then you transect the sternum. So you have access to both chest cavities and to the heart. So being able to transition this incision that is extremely traumatic and slows patient recovery, longer hospital length of stay, and a lot slower functional recovery. If you're able to make this incision a lot smaller, and we're talking now about doing a lung transplant at Jackson through an incision that is 10 centimeters on each side, I think already seeing massive improvement in terms of how fast our patients get back to a functional, close to normal life. And I think that the next step is really being able to do this through robotic surgery. So what if you're able to do a double lung transplant with 2 centimeters incisions in your chest, and then you can use a small abdominal incision to bring the donor lungs through the diaphragm. I really feel like this is in the near future, and I think that this is going to have a massive benefit for patients suffering from advanced lung disease.
Giselle.
As a medical person, I really need to attest to how wonderful innovation is to making the lives of our patients so much better. I see Dr. Vianna and Dr. Machuca operate robotically our patients, and I actually have had several patients come and tell me afterwards, it hurt more to get a wisdom tooth extraction than to get my kidney out. They've literally only taken 2 Tylenols for the whole entire length of their stay afterwards. And so they were able to go home and live a functional life. And it was probably one of the most rewarding things, if not the most rewarding thing they ever did in their lives. So I actually think it's gonna increase awareness of helping others and increase the need for donation in this country and throughout the world.
One more thing, if I may. Rodrigo, you mentioned to me when you did the extraction of a kidney from a live patient as a donor, robotically, what did that mean for that patient, and how long did it take for that patient to get back home, and how did that work?
So the donor operation with robotics has really changed. We do them pretty much in less than an hour. The operation is less than an hour, and patients go home same day, and a week later they walk into the clinic and they have taken only Tylenol. So, I mean, we know that life, and I think, transplantation, you don't pay attention to transplant unless you know somebody, there's somebody in your family that needs one. Otherwise, we don't pay attention to it. But the reality is that if you donate a kidney, your life expectancy is about the same or even better, because now you take care of yourself than if you don't. So it's really revolutionizing. The first pancreas transplant that we did, a patient went home in 5 days with a pancreas and a kidney transplant and wrote a book about it. And so I think it's a revolution. Training, teaching, smaller incisions, better matches. So I believe we're experiencing a revolution.
The next topic is going to be perfusion. And let me, for those of us laymen, let me explain a little bit of what that is, especially here in Miami. Miami is not a great donor city. There's a lot of people that do not wish, when they pass, to donate their organs for a lot of personal beliefs. So it's a challenge to be able to provide the organs, and we do 600 to 700 organs a year. So imagine what that means, and it doesn't mean one person for each one of those organs. It could be obviously 6 or 7 organs out of one person, depending on the condition of the organs. But those organs, once extracted from that person, have a limited amount of time, and in some cases, those organs may not be 100% right for donors. So they've created this machine and process called perfusion. So in talking about how we are integrating perfusion into transplantation to get more available organs for the future. So Giselle, why don't you talk a little bit about what that means to Miami specifically?
So for Miami in particular, geographically, we're at a disadvantage. And again, we have many individuals that are suffering from organ failure, in particular kidney. That being said, we need to understand how are we going to get the organs here. So for kidney transplantation, there are special machines that we have in place to actually help preserve and hopefully optimize how long those kidneys are going to last. We wish we had more organs available to us locally, but unfortunately we're surrounded by water, and so we don't have the availability that other places throughout the United States they have. So we've been lucky enough that we've actually learned how to work with these machines to actually make those organs, those kidneys last longer, so we could actually get more individuals transplanted. And actually with time, we're learning there's even more advancement in technology to make certain things happen. We started with what we consider a hyperperfusion machine, but now we're looking into normothermic machine. And that is probably the closest thing that we have to what it would look like when we transplant an individual with that organ. And so medicine is being utilized to optimize these organs to make certain things happen. And it's not only for kidney. Dr. Vianna could explain now how it works for liver and how we're able to actually get more individuals transplanted as a result of that.
Thank you. Want to add something?
So in terms of perfusion, when we remove the organs from the body, the time starts, the clock starts, because you don't have blood flow, and the cells, they start dying because they're out. So we got to find ways to get the organs where they need to be and to perfuse them so we can prolong that. Several ways to do it. You can keep them hypothermic, like low temperature, or you can give them normothermic, which means perfusing with blood. So if you could mimic the body and perfuse with blood and treat, look at labs, and actually improve the organs during that time, since we're talking about the future, I believe the future is going to be places, hubs, where organs are going to go there in normothermic perfusion. They're going to be improved, and they're going to get ready to transplant, and then they're going to be shipped to places where they're going to be transplanted. So I think the entire allocation, I think the boundaries are going to change because now we can ship organs further, we can treat them, we can improve them. So I believe that's going to change. And also subthermic, sub-zero perfusion. There is some work being done on stabilize organs even below zero without creating crystals. So the problem when you go below zero is that you got ice. So what if you could go very close to zero or below zero and not create ice? So then it will kind of stop the metabolism of that cell, and you could rewarm the organs later and then get them back to life. So I believe it's another revolution between xenotransplant, perfusion, robotics. I think this all comes together to help even more people. We're very restricted to the people that actually apply for transplant, right? We have to be careful because we can't transplant everybody or include everybody on the list. I think as organs became available through xenotransplantation, perfusion machines, robotic surgery, I think we're going to extend the help and go into oncology and other areas that could benefit from organ transplantation.
So you just imagine how fascinating it is in the lung transplantation field that you can extract a pair of donor lungs from a donor and keep it alive outside the body. So that lung is being ventilated and perfused at normal body temperature. So what this means is that any therapeutic intervention that you would utilize in a patient, now you can utilize in an organ. So you're treating an organ outside the body as if you were treating a patient. And you can personalize the therapies you're going to deliver. You can use diagnostics to understand those donor lungs, they're suffering from pneumonia, so we can treat it with antibiotics. And we know today that we're able to, over a period of 12 hours, 24 hours, decrease the amount of bacteria in those lungs. If those lungs are suffering from pulmonary embolism, you treat those lungs just if you were treating a patient and you deliver thrombolytics. You dissolve the clots with the same medication you would use for a patient into an organ. So I think that this is where we are embarking now, and I think it's going to be extremely fulfilling to be able to help more and more patients.
I'm going to bring up a word that became at least very popular, at least in phone calls from me, from people around South Florida during COVID, was ECMO. ECMO is a machine that we'll ask here Tiago to speak a little more about that in a second, that breathes and pumps blood for you while your heart or your lung cannot do it. And during COVID, when people could not breathe, they said, well, send them to Jackson because they got ECMO machines. ECMO is not a simple machine. You have hundreds of them hanging around. But Tiago, as our director of ECMO and how we deal with ECMO, can you talk a little more of the technicalities of what ECMO does and how that gives the opportunity of the person to live until we get to the next level?
Yeah, I think that the fact that we had to face the COVID pandemic, I think it really put ECMO in the spotlight, and I think ECMO saved so many lives, and we learned how to use ECMO better, and I think we're still having some benefits from what we learned on those days today. So just think how counterintuitive in pulmonary medicine it was that if your lungs are not working very well, now you're going to force through a ventilator air with a higher pressure and higher oxygen that can be toxic to your lungs. So this is how we work if the patient is in respiratory failure and you need to put that patient on the ventilator. So it's extremely counterintuitive. You're forcing those lungs with higher pressure and toxic oxygen levels, and you expect those lungs to recover. So with ECMO, with an artificial lung, we're able nowadays to, through the insertion of 2 cannulas, we can essentially drain all the blood from that patient and return it oxygenated and allow those lungs, those native lungs, to rest. And before COVID, we felt like the time frame that we could use this artificial lung therapy was very short, 7 days, 14 days. You won't believe that at Jackson, we received patients that were on ECMO to close to a year, 9 months, 1 year inside a hospital, being supported by an artificial lung that replaces essentially 100% of a patient's lung function. And those patients that are awake, they're ambulating in a hospital. So I think that this has completely changed the way that we approach respiratory failure to a point that if the engine is not working well, we utilize an accessory engine, but that accessory engine now doesn't have a time frame that is so limited that the clock is ticking. So I think that this is really one thing that we learned from COVID, and we're able to see patients having their native lungs recovered, or if they didn't recover, we could transplant them, again, in a time frames that could go as long as a year.
One thing that these two guys are working on that I think is very cool, and I hope we have enough time to discuss this further, it has to do with cancerous tumors in organs. There's been a time in which if you have pancreatic cancer, that people would say you have no chance, you're going to die. In many cases, lung and liver had some of the same things. Because if you couldn't do some minor surgeries to remove that tumor, there was never enough chances to do that. I know for a fact that both Rodrigo and Tiago have worked on transplantation oncology and how to deal with some of those tumors at what levels they can do, where transplanting organs to replace those malignant organs has made a difference. So let me start with you, Rodrigo, but I certainly want to hear also from Tiago on this conversation, because both of you guys are really at the forefront of this kind of transplantation.
So I'll try to go fast. So we can actually use the techniques from transplantation to do something that we call ultra complex surgery, which is basically you could technically cool those organs, remove them from the body, and we perform the surgery outside. Because you can't do the inside, right? You're going to have to clamp, you're going to cut important vessels. So what we do is called ex vivo resections. So a lot of the patients that will be deemed not resectable, be dying with the cancer, we can help them by doing the resection outside the body. And then putting the organs back, and they don't get damaged because we cool them during that period. So I think that's an advance. At Jackson Memorial Hospital, we have the largest multi-organ transplant in the world, which means 4 or more organs. We have performed 500 out of probably 3,000 done in the world, and a lot of those patients have slow-growing tumors. So I think there's a lot of advantages of merging oncology and transplantation because of the vascular work that we can do.
And I think if you look in terms of lung transplantation, I'm not sure if you followed on the news recently, but there was a double lung liver transplant that was done on a patient with advanced lung cancer. So I think that the future really is going to involve replacement of organs that are involved or damaged from cancer. But if you find the right immunosuppression and the right patient population heavily selected, I think you're able to save lives of people that they're deemed terminal. We had cases at our institution that they had stage 4 lung cancer, terminal, going to palliative care, and they underwent a double lung transplant. 2 years out, they are alive with no disease recurrence and no need for adjuvant chemotherapy. So I think that this is possible. I think we just need to evolve with more registries to understand how to better select these patients. But I do believe it's in the near future.
Tiago, I know for a fact, I mean, before Tiago joined us, we were doing an average of 12 to 15 lung transplants a year. And this last year we did 100. And it's not because we're doing anything, it's doing this with the same patients that were not being done before. What Tiago has done is through conferences, through meeting with pulmonologists around, have been able to identify with them how some of those patients qualify for transplant and in the past never qualified for transplant. So from that standpoint, there's 85 people in this community walking around that would have been dead a year ago if it hadn't been for the kind of work that Tiago's been doing. And that's just in 1 year. So the idea is how do we continue that working? But talk a little bit about, Tiago, how and what are the different things from the traditional transplantational lungs to what are the things you're looking at now that is really bringing a lot of patients that in the past pulmonologists would never have thought to transplant and now is making a difference in their lives?
I think it's funny how the docs connect through a journey for advanced lung disease. So when we started doing these more complex cases, we started to understand that some patients that were deemed non-salvageable in every lung transplant program in the country, how when you looked through the delivery of care with an extremely expert team that works in collaboration, some of these patients might be salvageable. So we developed this concept of a dedicated lung unit where those patients who come and everyone in that unit works 100% of their times with these patients that need ECMO, that need complex lung transplantation. And I think with that, how did we grow so fast? These patients were here, but the main aspect is that they were not offered transplantation before because based on conventional medicine, they were too sick for transplant. And I think that even though they might be too sick for transplant in 90% of the programs that you have, I think though you're going to find 10% of the programs that are willing to take on that challenge and then put the required human resources, hospital resources, to be able to deliver a favorable outcome to these patients. So I think a lot of our growth was related to looking at patients from a different angle and seeing, well, everyone said that this is not possible, but when we look, I think that together we can make this work. And then COVID followed. So then we had these more complex patients, and COVID followed. We were the second hospital in the country to perform lung transplantation for COVID. And even though everyone was telling us that we were crazy, we felt like there was really no absolute contraindication, and we could save those patients. And the rest is history. Every lung transplant program in the country started entertaining these patients and transplanting them 1-2 years later after we did our first one.
Thank you for that. Rodrigo, you recently went to India to fine-tune a little bit of robotic surgery. Why the hell did you have to go to India to learn anything about robotic surgery? Tell us what was different about that, and what what expertise did you bring back to our team?
Yes, I went because we never stop looking, right, at what's new. And it's incredible how around the world new things get developed. And we find incredible technology where the things that I talked about, it maybe perhaps bring the console of the robot, these big machines, directly to your eyes and control the instruments with your hand sitting in a chair anywhere. And we're very, I think we're very keen, we've always been very keen and looking around the world and see what we can bring back to Miami. And in a way, we're very lucky. You know, we're here in Miami with a beautiful hospital that is public and it sees everybody. We have the research behind of the University of Miami, so it's a perfect place to be if you need us. Like I always say that I hope you never need us, but if you do, Miami is the best place in the country to get a transplant.
Carlos, hi. I'm behind you. That's all the time we have, unfortunately.
Oh, how are you?
Can I get a big round of applause for our panel?